Okay, good morning, everyone. Welcome to Wednesday morning rounds. This morning we have Dr. Khalid Naji, one of our imaging fellows, who's going to give us a presentation on amyloid. And I just would like to remind everyone to register for rounds or attend rounds. Next week we have Dr. Hassan Mir, who's going to be speaking on smoking cessation. So welcome, Khalid. We look forward to your presentation.
Good morning, everyone. I'm Khaled Naji, one of the cardiac imaging fellows. Today, I'm going to present about the cardiac amyloidosis, and I name it amyloid Selvi because I'm cardiac imaging fellow, and I will focus more about the role of cardiac imaging for cardiac amyloidosis. And what I believe that the cardiac amyloid patients, that they are like easily missed. And the good things in the recent years, we have new imaging techniques to for better diagnosis of cardiac amyloidosis. Sorry. So I want to take the chance in my talk today to say thank you to my staff in the cardiology imaging, with a special thanks to Dr. Chow, Dr. Beelans, Dr. Rodi, Dr. Dick, Dr. Small, Dr. Peter Lu, Dr. Patterson, Dr. Christian, and Dr. Eugene. I started my fellowship 2 years ago, and I almost know nothing about the cardiac imaging, and I think I gain a lot. And just want to say thank you to them. My objectives for the talk today will be a simple introduction to the cardiac amyloidosis. Then I will give a brief about the some of the history the history and the examination findings, and approach for the diagnosis of cardiac amyloidosis, and the role of imaging modalities for diagnosis of cardiac amyloidosis. And at the end, I will give some practical points. I try to make my presentation short as I can, because in the first time when I finished my presentation, it was more than 100 slides. So I decided to just make it short for the sake of the time. So just in the history, I was searching when was the first time to use the word amyloid. So the first time it was used by a German scientist. His name is Matthias Sheldon. I'm not sure if I say it correctly. It was in 1838. He was describing like a plant material, and he called it like amyloid. Then in 1854, another German scientist, his name is Rudolf Virchow, he was doing some medical experimental on autopsy, and he was applying iodine solution to the nervous tissue. When he saw some reaction, he thought the body reactions may be from plant inside, like plant-based material in the body, and this he called it like amyloid. And the first time to use the term of cardiac amyloidosis was by a scientist. His name is Isidor Soika. This was in 1876. He was describing the disease of amyloid with heart involvement. So in the introduction, what's the cardiac amyloidosis? So cardiac amyloidosis is a broad term used to describe family of inherited and acquired disease characterized by extracellular deposition of insoluble fibrils. In the pathogenesis, we have several proteins that can potentially lead to amyloidosis as a disease in general. Actually, we have more than like 30 proteins that can lead to amyloidosis. For example, it can manifest as a disease. For example, we have the Alzheimer's disease, we have the Parkinson disease, we have Huntington disease, and others. And but few proteins or abnormal proteins that can lead to amyloidosis, and the main two categories is the AL and ATTR. So what's the AL amyloidosis? Is a systemic disease with prognosis driven largely by the toxic infiltrative cardiomyopathy. And for the ATTR is actually derived from transferrin, which is a protein binding, it's like a carrier for the retinol and thyroxine enzyme that and it can transport this enzyme to the rest of the body. And the transformation of this 127 amino acid protein into amyloid is stimulated by either two mechanisms, at least what we think is responsible. The first one is with aging, and they call it wild type ATTR, and the second type when there's genetic mutation in one of the genes that can lead to abnormal protein. So for the classification, again, we said the first type is AL. It's referred to the primary amyloidosis or the light chain amyloidosis, and is result of the unregulated proliferation of single clone of plasma cells, a monoclonal gammopathy resulting in the overproduction of immunoglobulin light chains that transform into amyloid tissue. The second type is the ATTR and is a result of abnormal buildup of amyloid deposit composed of misfolded transferrin ferritin protein in the body, organs, and tissues. The first type of the ATTR is the wild type. It can be written as ATTR WT, stand for wild type, and the other one is ATTR senile, and it's associated with aging. And just to mention again this issue, this point, no genetic mutations. The second type is the one with associated with genetic mutation, and we usually refer to this type with ATTR M, stand for mutant. H ATTR stand for hereditary ATTR, and ATTR V stand for variant. So in the ATTR, there is overproduction of abnormal protein, either with aging or with as a result of genetic mutation. The production is mainly by the liver. The TTR protein is actually in tetrameric form. That means there like 4 units of protein. This protein will misfold and end up as insoluble protein or fibrils that will deposit in body tissue. For the AL, there is a plasma cell dyskaresis and overproduction of immunoglobulin overproduction that will end with misfolding and deposition in the body. We can see here in the like in the histopathology, in the right side is the normal heart. When we see the normal fibers is arranged and stick to each others. In the left side here, we can see the amyloid deposit between the heart muscle that lead to stiffness and increase the size of the heart muscle. So regarding the prevalence, it's not easy to talk about the prevalence of cardiac amyloid. What we know is, in general, it's rare. It's more common in ATTR more than the AL. I search in the literature to see if there is any like a prevalence for cardiac amyloidosis in Canada. I found a review that was published recently from Alberta. They reviewed 3 cohort studies, and they said, or they conclude that between 2004 and 2018, the incidence rates of probable cardiac amyloidosis increased from 1.38 to 3.69 per 100,000 person per year, and the prevalence rates increased from 3.4 to 14.85 per 100,000 person per year. And I found this like nice table here from the Canadian consensus regarding the cardiac amyloidosis diagnosis and management. They said, just want to mention 2 points here. The first one, there's maybe slight male predominance in the AL and wild type ATTR, and the prevalence or the incidence actually of the AL is around 10 per million, and it's increasing with age. In this slide, just I want to show the classification again of the cardiac amyloidosis, and I will mention some typical age with of manifestation of cardiac amyloidosis. For example, in AL type, usually they manifest around age of 50, and with the wild type, they manifest usually at age of 65 to 70. With the mutant type, they can present earlier life, like at age of 40. For the A type, it's referred to amyloid A protein. It's usually associated with autoimmune disease, and usually they don't manifest with cardiac manifestation. For the genetic and clinical characteristics of the TTR, we have many variants. The most common two variants are the VAL122 and the VAL30-MET. The VAL122 maybe is the most the variant in the US, and the VAL30 maybe is the most common worldwide. And we should know that some of the variants, they differ in the cardiac manifestations. Some of them will present or manifest with mainly cardiac manifestation, and others they can present with mainly neurological disease. For the clinical manifestation of cardiac amyloidosis, actually it's not easy to diagnose cardiac amyloidosis because the symptoms of cardiac amyloidosis are vague, not specific. The most common presentation is heart failure, and half of them will present mainly with diastolic heart failure. And when we want to compare the ATTR to AL, usually the AL, they are more progressive when we compare to the ATTR, and the prognosis of AL type is worse. Just a few tips in the history examination. In AL type, they will present with renal disease. Most of the time, they can present mainly with proteinuria and nephrotic syndrome, and maybe they are not tolerated to some medications like the ACE, ARBs, and beta blockers. And they have around 20% of carpal tunnel syndrome that can present years before cardiac manifestation. And one of the pathognomic clinical finding or physical finding for AL type is the macroglossia, although the presentation of macroglossia is around 15%. And the other one, which is considered also pathognomic, is the preorbital process because of factor X deficiency. For the physical examination, it's not specific finding, but they can present with right side heart failure, volume overload, and hepatomegaly. In the ATTR type, they almost present the same with neurological disease, with the kidney disease, but less aggressive than the AL. They can have peripheral or central neurological disease. And in the physical finding, actually, one of the pathognomic things that we can look for the ATTR, if the patient has, is the ruptured tendon biceps is considered as pathognomic finding. So for the diagnosis of cardiac amyloidosis, usually we look for the ECG, the lab test, the cardiac imaging, and biopsy. And the biopsy, as we know, is the gold standard. So again, the diagnosis of cardiac amyloidosis, it's challenging because unspecific symptoms and the lag of the patient's presentation to the cardiology. In autopsy studies, they have found that amyloid deposition up to 19% of patients, even without clinical evidence. And the early diagnosis is important because now we have good therapies for both AL and ATTR that can prolong and increase the median survival rate for affected patients. For example, in AL, the mean survival rate was around like 3 to 6 months. Now with the treatment, it can reach up to 2 years or more. And should we approach the patient? I found this figure here from the Canadian consensus regarding the diagnosis and management of cardiac amyloidosis. It's simple, it's easy to use. They said if you have like one or more of the following, just you can suspect the cardiac amyloidosis and start investigation. For example, if there is established AL or ATTR diagnosis by biopsy, maybe from other organs, or if there is like peripheral sensory motor neuropathy, or if there's unexplained LV wall thickness detected in echo, or in case of low flow, low gradient aortic stenosis, especially if the age is more than 60, and the presence of carpal tunnel syndrome. So in the ECG, for us as cardiology, we like to see what we call the low voltage criteria on ECG. There are multiple definitions of low voltage. The most common used is less than 0.5 millivolt in the limb leads, and less than 1 millivolt in the pericardial leads. But we should not trust only the ECG, because we can miss a lot of patients. There was a study conducted in 200 patients, half of them AL and the other half is ATTR with both types. They were questioning some of the ECG findings, and they conclude that the low voltage criteria or the low voltage finding on ECG, it's ranging between 15 to 33%. So we can miss, I mean, a lot of patients if we use only the ECG. So what's the general approach to start investigating the cardiac amyloidosis? So if the cardiac amyloidosis is suspected by the history examination, the ECG or echo findings, we can, the first thing is to screen for plasma cell dyskaresis. We can do this by sending the serum and urine electrophoresis with immunoglobulin fixation and serum light chain assay. And this point is very important before proceeding to the rest of the investigation, because if it is high, and we talk about the ratio, not the level, because sometimes patients with kidney disease or even with aging, they have some abnormal levels. So we care more about the ratios between the free light chains. So if abnormal ratio, this will suggest that maybe the patient has cardiac amyloid AL type. If that's the case, we can proceed with bone marrow biopsy. We can consult the hematology. And if the ratio is like normal and the free light chains are also normal, so maybe the case is ATTR, so we can proceed with technetium study using the BYB scan. And if the test is not clear or equivocal, we can proceed with the other tests, for example, endomyocardial biopsy. After diagnosing the ATTR, we should do genetic testing just to make sure and differentiate between the two types of ATTR. Is it like mutant type or wild type? So what we are trying to answer from our investigation, we want to answer this box: is there any systemic amyloidosis? Yes or no? Is there any cardiac involvement? And if the cardiac amyloidosis is ATTR type, is it AL and ATTR? Because they differ in management and in prognosis. And if we know the ATTR, we should know the type of the ATTR. Moving to the imaging part of my talk today. So I used this review. It was written by Dr. Sharmila Darbulla and her group. It was written by a group of experts from different society, like the ASNIC, the AHA, the ASE, and other societies. And they give some recommendations in the and summarize the evidence and recommendations to use the cardiac imaging. So I will start with the echocardiography. So in echocardiography, Just want to play. So what are the echo findings of cardiac amyloidosis? So as we can see here in the echo, there is like thickened myocardium, there is thickened valve, thickened intraatrial septum, biatrial dilation, pericardial effusion. These findings are well described and correlated with the cardiac amyloid, but some of them they are not specific to cardiac amyloidosis, and maybe they present late in the disease. Again, I'm showing in this picture some of the findings. I just want to mention one thing. One of the findings that we usually describe is the sparkling shape in the echo. It's described with the cardiac amyloidosis, but again, it's not specific. Patients with for example, kidney disease, they can have this finding. Other findings also in the tissue Doppler, we can have the 555 sign, and this it can indicate restrictive pattern of disease. And another imaging technique that we can use is the speckle tracking echocardiography. So as we know that the heart has 3 layers, and they differ in orientation when they contract. So, for example, the endocardium, the orientation to contraction is longitudinal, and the radial is and the midwall actually is the orientation of contraction is in radial shortening, and the epicardium is circumferential shortening. So in case of cardiac amyloidosis, a pattern of reduced longitudinal shortening with preserved LV ejection fraction and radial shortening is characteristic of cardiac amyloidosis. Both AL and ATTR cardiac amyloidosis patients demonstrate typical pattern of distribution of speckle tracking echocardiography, derived longitudinal strain in which basal segments are severely impaired, with while apical segments are relatively spared. As we can see here, the normal, the more negative, the more normal, and the more close to the 0 is the abnormal. So we can see the lines here, they are referred to the apical segments, and they like abnormal. The usual cutoff is minus 13 or lower. And we can see here in the bullseye for the strain, what we call a Sheridan top sign pattern is specific and highly suggestive for cardiac amyloidosis. And here's some of the recommendation, how should we report the cardiac amyloidosis. I will skip maybe some of the slides here to catch with time. But at the end, we should say if the echo findings are not suggestive or strongly suggestive, then you can proceed with other medications. For the MRI is has a central role in non-invasive cardiac amyloidosis due to ability of to provide tissue characterization in addition to high resolution morphological and functional assessment. And the MRI has the ability mainly to do 2 things: differentiation between the cardiac amyloidosis and other cardiomyopathies, and detection of early cardiac involvement in patients with evidence of systemic amyloidosis. In this slide, I just want to mention some basic things that we look usually in the MRI, especially for the cardiology residents and general physicians, because maybe they are not familiar with the cardiac MRI like the echo. Usually you look for T1, and T1 is a way to quantify the intra and extracellular volume. The ECV, simply it's after giving the contrast, we are trying to quantify the extracellular volume simply by take the difference between the post contrast and the pre-contrast. And also we check the LGE, stand for the late gadolinium enhancement, because the cardiac amyloidosis has some typical patterns. And also we can assess the myocardial nulling. I'll show it in the next slides. And other findings like the echo, for example, the thickened myocardium, small LV cavity, pericardial effusion, and others. I mentioned this. So So what we like to see in the MRI, we like to see this black donut shape, which indicate normal myocardium. But in case of cardiac amyloidosis, usually we can see circumferential LGE to transmural. Other patterns also can be seen, like focal patchy, mainly in the basal segments. Other LGE pattern that we can see some enhancement in the atria and in the bulbs. For the normal nulling pattern, it's one of the early findings and described findings in the MRI for cardiac amyloidosis. So what we mean by normal nulling, that's mean the sorry. So we mean by the normal nulling when the blood pool is nulled before the myocardium, but in case of reverse or coincidence nulling, this will suggest cardiac amyloidosis, and it is very sensitive finding. So how far is the MRI sensitive, especially with the use of gadolinium? In one meta-analysis based on seven published studies, they estimated the sensitivity and specificity of 85 and 92 respectively for CMR-based LGE in diagnosing cardiac amyloidosis. Can we diagnose the patient with cardiac amyloidosis without giving the gadolinium? Because a lot of patients, they have maybe kidney disease and we cannot give the gadolinium. So they demonstrate some examples of different cardiomyopathies. Normal case in this column, and end stage disease with no cardiac involvement, HCM, AL, and ATTR. We can see the T1 here, and after giving the LG. So they try to analyze if there is like a cutoff for T1 that can help to differentiate between the cardiac amyloidosis and other cardiomyopathies. And they said we can use the T1 to diagnose patient with cardiac amyloidosis based on the T1 value. If the value is 1164 milliseconds, this will suggest cardiac amyloidosis. If less, maybe we should consider another testing. Other techniques that are promising to be used in the cardiac amyloidosis, for example, the T2 can be used maybe to differentiate between the cardiac amyloidosis because as we know that the AL type, it has some cardiotoxic effect in the myocardium cells. So maybe there's some edema, and the T2 image is specific more for edema. So they said if in this study, it was conducted in 42 patients, half of them AL type. They said if the T2 value are high, maybe this will suggest more of AL type. It's a small study and need more validation. Also in the study, they said one of the best prognostic marker was the ACV. And this finding was also described in other papers. Here again, some of the recommendation what to look for in the cardiac MRI. For example, the systolic function, the LV thickness, the stroke volume index, the LV mass, the atrial size and function, and the LG pattern as we describe, the myocardial signal suppression pattern, and the quantification of the amyloid infiltration. And at the end, we should say, as we said in the echo, is the MRI finding is suggestive, not suggestive, or strongly suggestive, or equivocal based on our findings, and then we can proceed to other investigation if needed. For the radionuclide imaging, the radionuclide imaging plays a unique role in non-invasive diagnostic cardiac amyloidosis. We have mainly two or three types of radionuclide imaging. The first one is the bone-avid radiotracers. They call it bone because previously it was used to investigate patients with bone cancers and to look for any metastasis. But they found that some patients, they have uptake if they have cardiac amyloidosis. The other one is the beta amyloid binding radiotracers, the autonomic myocardial intervention imaging. So for the bone-avid radio tracers, the reason may be behind how we can see some binding of the radio tracers, maybe because it's like attached to the microcalcification that associated with the cardiac amyloidosis. We have three kinds of radio tracers: the BYB, the technetium BYB, the technetium DBD, and the technetium HMDB. What's available in Canada is the BYB technetium. And in the absence of cardiac amyloidosis, there is no myocardial uptake in the bone tracers. It's very sensitive finding. I'll skip this. So regarding the sensitivity of the and specificity for the technique, the bone-avid tracers, I found two studies that showed the technetium. For example, the BYB study is very sensitive. The sensitivity in one study, it reached almost 100 for technetium. And in another meta-analysis, it showed also sensitivity of 92 and a specificity of 95%. Here is another algorithm suggested for patients who underwent to technetium before the serum and urine investigations. We have a scale 0 to 3. It's called Bergoni grading scale. According to the myocardial uptake, we can grade the patient to 0, 1, 2, or 3. I will show it in the next slide. So for diagnosis of cardiac amyloidosis, we have the semi-quantitative imaging. For example, in this image here, we can here there is no myocardial uptake when we compare it to the bone, to the ribs and the sternum. Here there is uptake, but less than the ribs and the sternum. Here is equal, and the myocardial uptake in grade 3 is more. So for the diagnosis, if the uptake is two or more, this is highly suggestive for cardiac amyloidosis ATTR type. If less, it's equivocal. In case of equivocal, we can do the quantitative measure when we apply or quantify the uptake over the myocardium and the contralateral lung. And we can do images in 1 hour or 3 hours and check the ratio. For abnormal ratio in 1 hour, if the ratio is more than 1.5, or in 3 hours more than 1.3, this can help us to suggest if the equivocal results are suggesting cardiac amyloidosis or not. Here another example of the radio tracers uptake. It's also recommended to do SPECT studies and CT to just make sure some of the uptake is not in the blood pool. For example, here we can see there is maybe a positive study, but when we do the SPECT images and CT, the actual uptake is in the blood pool. And here is another example for true uptake in the myocardium. I brought this from ASNC recommendation, what we should comment and check in our study. This summarizes what I said before. I found this new published article. It was comparing the BYB study to patients with the MRI. It was a large study. It was around, I think, 300 patients. So just in the sub-analysis, they said, what should we do with the grade 1 uptake in the DBD, technetium DBD? They said if some of the grade 1, most of the grade 1 uptake is mainly because of the AL, but it could be also from other ATTR variants. And what we can use from the MRI is to check the ECV. If the ECV value is more than 40, this will suggest more of AL. If less, it suggests maybe ATTR or other variants. For the BET-based cardiac amyloid tracers, why we need the BET tracers? We need another like imaging that can do three things. It can like identify the amyloidosis and to see if there is any cardiac involvement to differentiate between the cardiac amyloidosis AL and ATTR type, and if it is, can help in follow up the patients. And the PET tracers was used first for detection of amyloid in case of Alzheimer's disease. We have mainly four types of PET tracers so far: the CPEP, the fluorpitapir, the fluorpitapin, and flumetamol. For the CPEP, it's one of the early PET tracers that's discovered for the cardiac amyloidosis. And what they observe that when actually few studies were done to compare the CPEP uptake between the AL and ATTR and compare it to other control healthy groups. And it showed selectively uptake of the PET tracers uptake in the cardiac amyloid patients. In another study, it showed that the CPEP uptake in patients with V30M mutation with type A and type B fibrils. However, but mainly in the type B, because most of the ATTR type, when they deposit in the cells, they deposit in a form of what we call type A fibrils. But it could be sometimes deposit as type B fibrils, and this type may be difficult to image in the usual SPECT studies or the PYB study. But they found that the CPEP maybe can detect this type of ATTR variant. However, the technetium DPD uptake was elevated in type A again, and it was absent in the type B. So this data suggests that maybe the CPEP might be a sensitive marker for early detection and raise the possibility of studying this agent in carriers of mutations to detect early disease onset. The second PET tracer is the fluorpitapir. The tracer was examined in patients with AL and ATTR, and it showed uptake in both cardiac amyloid types, but higher in the AL. So far, we cannot use the PET tracers to differentiate, but there is a promise that it can help. In another study, they investigate the tracer in 40 patients with active AL and in patients on remission. They found there is uptake in both groups, and these data maybe suggest that the fluorpitapir hold promise for evaluation of fibril deposition in systemic AL amyloidosis, and it may successful to monitor organ response to plasma cell and antifibrillar therapies. The third PET tracer is the fluorpitapin. There was the first PET tracer study to show correlation between the PET tracer retention and biventricular contractive function via inverse curve relationship, suggesting that it may have a role in monitoring the burden of cardiac amyloid plaque and response to therapy. The myocardial tracer retention is correlated with the parameters as measured with the MRI and echo. And in 4 patients follow-up in one study, it was then after treatment initiation, it showed some changes in the tracer retention from baseline to follow-up correlating with the treatment response. And these data suggest that the fluorpitapin is a feasible technique for differentiating among cardiac amyloid subtypes. The fourth type is the fourth PET tracer is the flumetamol. In a small study of 9 patients with cardiac amyloidosis, 1 with AL and the rest with ATTR, and 3 are controlled. The study showed uptake in 11 of the 12 patients. And the target to background ratio was also significantly higher. Again, there is some promise that it can help in detection of cardiac amyloidosis. Also, one of the things that we can look for is the autonomic myocardial innervation by using the MIBG uptake imaging. It has established the tracer for imaging myocardial denervation, and it has utilized to image the myocardial innervation in familial type of ATTR amyloidosis. And the cardiac sympathetic degeneration is associated with decreased survival in ATTR variant type, and a late decrease in the heart to mediastinal ratio to less than 1.6 pretend a poor prognosis and can be used to identify the ATTR variant. Here we can see the normal type, and here we can see the abnormal type. Just a few slides here about the cardiac CT. So there is a new technique that can be used in the cardiac CT. Same way we do with the MRI. We can try to quantify the extracellular volume and simply just by acquiring one image with the patients who undergo to cardiac CT for another indications. And why this is important? Because multiple studies found that patients with heart failure, for example, they have 13% of patients with heart failure with preserved ejection fraction, and in 1 to 7 of elderly patients with 75 years age or over with severe AS, they have cardiac amyloidosis. So the ECV quantified by CT is in one study it showed some correlation with other imaging, for example the MRI and the echo, and it can associated with it can give us some hints about the prognosis of the patient. In the example here, we can see the ECV map here with apical sparing like the sharing top in the echo. We can see it also in this patient with ATTR. Here, the ECV is mainly in the subendocardial area, and this results not because of the ATTR, it's a result because of previous infarction in the LCX territory. And patient in device, actually it helped when we cannot do MRI. This patient was diagnosed with ATTR and the ECV here was elevated. The ECV can change with different type of cardiomyopathy, and it can be very high in case of cardiac amyloidosis. So regarding the follow-up, we can do follow-up mainly by the echo. When we can do some repeated like a strain pattern for the echo, and in patients with good response, the strain pattern will improve. So here it was mainly preserved in the apical segments and start to improve and improve, and the values become like more and more negative. That indicates there is good contraction and response to the treatment. Also, we can use the MRI as a follow-up. We can follow, for example, the T1 value, the LGE, and the ECV. As we can see here, this MRI was done over 16 months following treatment of patients with AL who received treatment. So we can see there's like a lot of LGE, and with time it disappear. And in patients, when we want to use the bone avid tracers, we can use it mainly for follow-up if there's like worsening condition, but not to assess the response. So for example, in this patient, it was done over 2 years, and we can see the myocardial uptake with time is worsening. I think here it was like 2003, and here it was 2018, and there is like worsening of myocardial uptake. Here I want to show some of the parameters that maybe suggest changes to treatment. For example, we can see some regression of the wall thickness, for example, 1 to 2 millimeters reduction in 3 to 4 years, and some improvement in the ejection fraction, more than 20% in 4 years, and some improvement in the global longitudinal strain. Some apical and basal strain ratio will improve also in the echo. In the MRI also we can see some improvement in the ECV, like CV reduction of more than 5%. and the some reduction in the left ventricular mass. So in the first year, what we expect to see, we can see some improvement in the global longitudinal strain, some improvement in the mass, and maybe increase in volume. And in 6 months, we can see some changes in the LV dimensions, in the stroke volume index, in the tissue Doppler findings, and also in this review, it was written as a second part for the initial. I'm not sure if I have time. So the group, they try to make a recommendation. Like they are trying to make some practical recommendation in how to use the cardiac imaging. I will skip this slide. It's just mainly how to diagnose the cardiac amyloidosis. So yes, so for the so they make around 32 scenarios when we should use the cardiac imaging, and mainly by using the echo, the MRI, and the BYB study. So the first group of scenarios mainly to identify cardiac involvement with no cardiac symptoms. So for asymptomatic gene carriers, for asymptomatic patients, if there is like biopsy-proven systemic AL amyloidosis, it's not maybe wise to do or to proceed with the radiotracer using the BYB, because the most likely is AL, and AL is not usually detected in the BYB study. And if the patient, for example, has some elevated free light chains or abnormal free light chains, again, maybe this will suggest more of AL. So maybe it's not wise to do the BYB. Otherwise, we can do the echo and MRI. The second group of scenarios is mainly to screen patients with cardiac amyloidosis with new symptomatic heart failure. We can use any imaging modality like the echo, the MRI, but again, in the for the bone tracers, maybe it's not recommended again if there's any elevated free light chains that suggest maybe AL. The same here. The third group of scenarios, if we want to evaluate patients with biopsy-proven AL type. So for the evaluation, we can like do echo, and for the follow-up of the patients, we can again do echo. For the MRI, maybe it's recommended to repeat the MRI in 1 to 2 years. And since the case is AL, so there is no rule for the technetium studies. The third group, we want to evaluate patients with ATTR cardiac amyloidosis. So there is no rule for a BYB study for follow-up, but we can use the echo and MRI. The MRI, again, maybe it's recommended to do in 1 or 2 years to check the response and follow-up. And regarding so in the fifth group, when we can repeat testing. So if there's any new or worsening of cardiac symptoms, actually we can go and repeat testing with echo, with MRI. But if there is any suspicion of AL, the technetium studies are not the first line. And they give some recommendation to investigate patients that maybe they have a risk or red flags for cardiac amyloidosis. For example, patients more than 60 years with unexplained bilateral carpal tunnel, patients, individuals with unexplained bilateral carpal tunnel syndrome and elevated free light chain levels, patients above 60 with heart failure and unexplained biceps tendon rupture, and adults, especially elderly men with unexplained neuropathy and other arrhythmias in the absence of usual risk factors and no signs or symptoms of heart failure. And if the last scenario, when there is a prior testing suggesting cardiac amyloidosis, actually we can maybe choose go between the imaging, but mainly maybe if there is abnormal echo, we can go as a second line the MRI or the opposite, just to avoid maybe the radiation. And it's depend actually in the scenario. If the suspicion of ATTR is high and the lab results with free light chains are normal, we can proceed with the PYB study. Thank you so much. Sorry that I take maybe longer time, and I'm ready for any questions.
Thank you very much. So if anyone has questions, you can please put them in the chat box, or we'll unmute your microphone and you can ask Khalid your questions. I'll have a question to start with. So is it true then with the pyrophosphate scan that if you have AL amyloid, notwithstanding that that's not the way you start with your algorithm to assess it, but if someone were to have AL amyloid, which was not expected, and you did a pyrophosphate scan, would the pyrophosphate scan be positive?
So in case of so usually the ATTR uptake, if the case is ATTR, the uptake will be more significant. The grade will be 2 or higher. If it is grade 1, there is chance that there is AL type that's associated with the pyrophosphate uptake. So the answer is yes, it could be AL amyloidosis.
It's Gary Small. Great talk, Khalid. Well done. Lots and lots of information. I think I had 2 points just to follow up. Really, we've not seen that here with AL. It is described. You're right. Grade 1 uptake has been described, but we haven't seen it. And so we've been, as we've kind of learned with our pyrophosphate scanning, we've actually scanned quite a lot of AL patients as well to make sure they didn't have concomitant ATTR. You know, particularly in the elderly group, we know about 10% of the patients who have ATTR may have monoclonal gammopathies as well. So we've not found anybody here with AL that has a positive pyrophosphate, but we'll kind of keep obviously we'll keep looking at that. The other question I had was in the clinic, you know, how do you obviously there's a lot of information here, but how do you decide who to test? What do you do? So somebody comes with HFpEF to your clinic, you're going to do a physical examination, and then what will you do?
So I will start with the history examination and echo. If there is like multiple red flags, for example, the patient has polyneuropathy, they have carpal tunnel syndrome, they have unexplained HFpEF, or they have maybe increased LV wall thickness in echocardiogram, but the patient is not hypertensive. So this maybe will give me a hint to start investigating the cardiac amyloidosis. In different scenario, if the patient has like family history of cardiac amyloidosis, we should also investigate. And for example, if the patient had MRI, cardiac MRI test, and they incidentally find some findings that can suggest cardiac amyloidosis, then I think with the clinical finding, we can maybe start investigating the cardiac amyloidosis.
That's great. I think one of the big messages to put across is that this is a misdiagnosis. Like the time delays to diagnosing AL, for example, is about 8 months. For ATTR, it's 18 or longer, so 2 years at least from symptom development. Prognosis in AL can be as short as 6 months. So, you know, if you have people with HFpEF who we think may have a monoclonal gammopathy, we really need to get like a serum-free light chains, a serum protein electrophoresis, etc., done early. It's so important, right? And it's still not on our kind of radar as cardiologists, this disease. So I think that's important. My last point before I hand over the mic to somebody else is that just you mentioned a bit about regression of disease, and I think that's really in AL. What tafamidis has been very good for in ATTR is holding the disease. So we don't see a lot of regression. It really just stops progression of the disease. And so that does mean that we don't give it to patients in stage 4 heart failure or with dementia, this kind of poor prognostic group. We limit treatment to kind of grade 1 to grade 3 kind of levels of heart failure. Then, but there has been a few case reports of regression on the silencer therapies in ATTR. So I think that's very exciting. And there are new treatments coming in now to disrupt the ATTR fibrils. So those are only in phase 1 trials at the moment. In AL, over time, there are reports of regression, as you kind of indicated. That's great. I don't know if there are any other questions, Ellie.
That's great. Thank you. Just going to check one thing here. If anyone else has any questions, please put them in the chat. Otherwise, there's a question from Dr. Chan. Is immunofixation different from electrophoresis?
So the immunofixation is different, but to be honest, I'm not sure in what way, but usually we do both. So the electrophoresis usually we send for the serum and urine, and also we send for immunofixation. I'm not sure if anyone can help in this, because to be honest, I'm not sure about this. Any help, Dr.
So very, very briefly, I'm not a hematologist, but we're learning about these techniques. So basically, when we do serum electrophoresis, we see the proteins run out on a gel, and we see different bands. So serum protein electrophoresis enables us to identify an abnormal band and quantify that band. That helps differentiate things like MGUS from more malignant plasma cell dyscrasias, depending on the amount of protein that's in that band. Immunofixation is a longer incubation and is more time consuming. So the lab is reluctant to do that on all our tests, and actually is cutting back on the number of immunofixations that are done. So they will do it when they pick up an abnormal band, but they won't do it on everybody. So essentially it's a longer incubation period to identify then what is in that abnormal band.
Just a comment from Dr. Burwash that the lab will not do immunofixation without discussion with the biochemist. So your first point of order is your electrophoresis, which you can order as your SPEP or your UPEP. Excellent. Okay, I'd like to thank everyone for joining today. Thank you very much for that review, Khaled. Please sign up for next week's presentation. Dr. Mira will be talking about smoking cessation. If you did attend in person today, please sign the attendance sheet at the back so that you get credit for your CME. Okay, thanks everybody. Have a good week.